Good evening and welcome to this series of talks that we are having from AMMA Healthcare Research Gurukul, a set of multidisciplinary talks on health and different aspects of healthcare that we have titled Health from the Heart. And as part of these conversations, we aim to bring together experts from different fields of different disciplines of medicine and see how we can align different aspects of medical care to provide a more comprehensive and holistic care for the people. And in this particular conversation, we are going to focus on pregnancy, hypertension in pregnancy or pregnancy induced hypertension. And we have two eminent panelists with us, Dr. Sunil Pandya, who is a very well known, experienced pioneer in obstetric anesthesia in India, who has founded the Prerna Anaesthesia and Critical Care Services in Hyderabad, who is an executive member of the Oceania Society of Obstetric Anaesthesiologists, who is a visiting faculty in many teaching institutes, who is a visiting consultant in many advanced tertiary care institutes, is an editor for several journals related to obstetric anesthesia, and has headed obstetric anesthesia societies in India in different capacities as the president as well as the honorary secretary. Welcome to the show, Dr. Sunil Pandya. Our next panelist is Dr. Rijo Mathew Choorakuttil, who is a radiologist with a passion for fetal radiology, who has founded the Samrakshan program of the Indian Radiological and Imaging Association that aims to reduce perinatal mortality in India through an approach that integrates fetal Doppler with routine antenatal scans. And he has done pioneering work and built a team that's focused on that and has produced great results. He is also the national coordinator for the Preventive Radiology Initiative of the IRIA that started recently, and is a member of the Quality, Safety and Standards Committee of the Oceania Society of Radiologists. He is also the lead for developing magnetic resonance imaging safety protocols and guidelines in India as well as for countries in the Asia-Oceania region. So welcome to this conversation, Dr. Rijo Mathew Choorakuttil. And to begin with, let me start with Dr. Sunil Pandya. We know that pregnancy-induced hypertension or preeclampsia is a major problem in India, and it leads to several complications during childbirth that includes death of the mother, death of the fetus, severe conditions, severe adverse consequences that can be classified as near miss conditions or conditions where the mother nearly dies but survives. Several long-term and short-term consequences on the fetus. We also know that preeclampsia and pregnancy-induced hypertension are not new conditions. They are there for several decades, centuries, and yet we are still struggling with these conditions in India. It's one of the major causes, even after all the efforts that we are putting. So from an obstetric anesthesia perspective, I would like you to talk about two aspects mainly. One, as an obstetric anesthetist, what is the magnitude of the problem that pregnancy-induced hypertension gives you during your clinical practice? And two, why does this still remain a problem in India?
Thank you, Dr. Praveen, for the generous introduction. As you rightly said, preeclampsia or hypertensive disorders in pregnancy is still an issue. It's been continuing since centuries and even decades. Even today, if you look at our mortality, one of the commonest cause of maternal mortality in India today is hemorrhage followed by hypertensive disorders in pregnancy. And it's one of the top three leading cause of maternal mortality in India today: hemorrhage, hypertension, followed by sepsis. So it's an issue which cannot be ignored. And as a clinician, as an anesthesiologist and bar intensivist, I say that this women are a special group of women who requires not only the knowledge set to tackle these women, but also the skill sets. Because I would say, if you look at the complications that arise because of hypertensive disorders, they range from cerebrovascular accidents to acute kidney injuries to seizures to breast syndromes to acute multi-organ dysfunction syndrome, which requires organ supports and perioperative stiff organ supports also in the perioperative period. In fact, if I review my own statistics, 12% of women they require ventilator support, and at least about 7 to 8% they require massive transfusion because of various causes, either returning PPH or HELP syndrome leading to coagulopathy. So these are the things which makes this woman special subtype. And as a clinician, we need to be aware about what all can hypertensive disorder can cause, and it is best to optimize them before surgery, before delivery, and so as to have a good outcome both for the mother as well as for the fetus.
Now, one thing that I am aware that you have been spearheading and you have been highlighting often is that the need for the pregnant woman to be seen much earlier
Actually,
during the course of pregnancy, and not just before a planned emergency or a planned cesarean section or something like that, but that in the first trimester itself you would like to see the woman, you would like to do a detailed assessment of the woman, a detailed history, and then know if this particular woman is going to be at risk for adverse events.
yeah.
Do you think that this is something that is routinely done? It is something that must be routinely done. You're spearheading it, so I'm sure you think it must be routinely done, but do you think that this is something that is being routinely done? And if
Sadly, the
yeah.
answer is no. It is not being routinely done in majority of the center. If you look at again the magnitude of deliveries that happen, 70 to 75% of deliveries happen in nursing home. And one of the nursing home practices doing a pre-anesthetic check just before delivery or before cesarean section or on table when the mother is for surgery. And hardly you have any time to have a detailed assessment. But ideally, in ideal situation, like in because as an institute at Fernandez Hospital, we have a dedicated pre-anesthesia clinic wherein we see this woman early in pregnancy, especially around the patient is high risk woman. What I mean by high risk is any mother who has advanced maternal age, who has high BMI, who has multiple medical problems like connective tissue disorders, SLE, plus syndromes, or who have hypothyroidism on medications or pre-gestational diabetes mellitus. All these are the risk factors for preeclampsia or hypertension in pregnancy. And whenever this patient I have these factors, these are all the compounding factors that makes your anesthesia also complex. So having known this patient, if we assess this patient in the first trimester, we can proactively involve ourselves as a perioperative physician and try preventive strategies. Like we'll get a lot of input from radiologists also in the first trimester. But again, there are certain biomarkers like SFLT and personal growth factor ratios, which can predict, and putting these women simple measures like putting them on aspirin 150 milligrams a day to an extent can optimize, can minimize this eclampsia or preeclampsia becoming progressive to severe preeclampsia. So I think we will get a lot of input from the fetal medicine or radiologist also in assessment or identifying a high risk from a preeclampsia viewpoint.
Thank you. This is a good point, maybe to get Dr. Rijo into the conversation. Dr. Rijo, you started the Samrakshan program primarily focusing on the same aspect, that an early first trimester identification of pregnant women who are at high risk for the major conditions, preeclampsia and fetal growth restriction, might help the whole process to uh, become easier. How did you conceive of this program, and how did this particular program go ahead?
Thank you, Dr. Praveen and Dr. Sunil Pandya. I'm extremely honored to share this platform with you in this series of conversations. And you have brought an obstetric anesthetist and in this platform, and a radiologist in this platform. I think we are the two silent people who are playing a big role in preeclampsia and the childbirth and pregnancy care, but often not seen. The invisible faces, faces in pregnancy care in India, but has got definitely some very important aspects to discuss and deliberate with national policymakers. The magnitude of a problem of preeclampsia in India. India, if you look at the perinatal statistics or the maternal or childbirth statistics, the pregnancy statistics, we are 25% of world statistics actually we are contributing in everything, whatever you take it, whether it is the perinatal mortality, whether it's the infant mortality, neonatal mortality, child under 5 mortality, maternal mortality, whatever indices you take, we are contributing to 25% of it to the world statistics. So if we can do something seriously to tackle this in India, by a strategy of risk stratification where medical professionals play a key role all across India with the help of their associations, we can make the policymakers think, look into these kind of activities and help to reduce this reduce these statistics and help to achieve a good results in the sustainable development goal. So this was the idea of conceiving this project of Samrakshan, because if you look at the incidence of perinatal deaths in India, they are nearly 7.5 lakhs, or nearly 25% of contributing to the world perinatal deaths. And if you look at the causes of perinatal deaths, 60 to 70% of causes are due to prematurity and complications and intrapartum complications. The two major causes for prematurity and intrapartum complications were preeclampsia and fetal growth restriction. So if we can address these two are causes that can be preventable and modifiable. And in that case, if we can stratify those mothers who are at risk for developing preeclampsia and those babies who are at risk for fetal growth restriction, we will be in better position to tackle this whole statistics, tackle this whole problem for India. This was the idea behind the project Samrakshan. And when we are looking at the way the radiologists were doing the pregnancy scans all over India, all over the world, there was a bias towards the screening for congenital anomalies and more towards the aneuploidy markers. But the 2.7 crores of live births in India, the incidence of aneuploidies are like a Down syndrome is less than 50,000. But those babies who are going to die due to fetal growth restriction, prematurity, and perinatal asphyxia and all those stuff is 7.5 lakhs. So there is a disconnect between the ground realities in India and the practice of fetal radiologists and fetal medicine specialists in meeting the necessary requirements of this nation. So this was the eye-opener for us, and we thought of addressing this issue with a protocol introduced in the Samrakshan, especially concentrating on two areas. One is screening, combined screening at 11 to 14 weeks with the help of maternal risk factors, assessment of maternal risk factors, mean arterial pressure, and uterine artery Dopplers. Though the Western literature includes the FMF Foundation and all includes the biochemical parameters, considering the pan-India perspective and the availability problems in availability of all these tests, we decided to first concentrate on these three parameters for the combined risk stratification over a period of 2 years. So our results gives us very large hope of we were able to pick up 80% of those mothers and who develop preeclampsia. And there is as per the aspirate trial, we can give 150 milligram of low dose aspirin to these mothers, and the incidence of preeclampsia can be reduced to another 80%, 60%. So if you have a 3 crore pregnancy in India, 30 lakh mothers are likely to have preeclampsia. 8 to 10% is the incidence of preeclampsia in India. So 30 lakh mothers, if you can screen them and can pick up 24 lakhs are positive for screen positive for preeclampsia and fetal growth restriction, and then give them low dose aspirin 150 milligram at bedtime till 36 weeks, we can reduce them. We can reduce the incidence of preeclampsia in 20 lakhs of mothers. That means this strategy, if we work out pan India, the possibility of in having preeclampsia itself can be reduced, because what Sunil was trying to emphasize is once preeclampsia develops and it progresses, the management part is really difficult. And again, it has got some long-term complications too. The chances of strokes, chances of chronic kidney disease, chances of chronic diseases in the postpartum period, all these things are going to be very, very high. So this is a strategy that Radiology Association thought about, that why not we skill enhance our radiologists to go for a combined screening methodology at first trimester to pick up those mothers and babies who are at risk for preeclampsia and fetal growth restriction. That was the first part of the Samrekshan project. The second part was the staging of fetal growth restriction and to look for any signs, any uterine Doppler findings that can be related to development of preeclampsia. But that is only a staging which can be, once the disease process has started or once the preeclampsia has set in, the management, these Doppler studies may not be of much use unless and until you may be in a position to stage the progression of fetal adaptation towards a hypoxic and a hostile environment. So the problem of preeclampsia is really, really high in India. So we have to address it in a way where a preventive strategy to stratify the risk of those mothers and babies who are at risk. So that was the whole idea and concept behind Samrekshan, and we executed the project in 40 districts in 15 states in India. And our 2-year results, in which Dr. Praveen Nirmalan also was the chief research mentor of this project, and he has been tremendously helpful for and a great guide for us in this program. And I think many of the statistics that we have come out with the 2-year results, which is getting published in the Indian Journal of Radiology and Imaging in this issue, Praveen will be can highlight them, and at least Praveen has sent me a message that you can pat on your shoulder for initiating this project. Thank you, Praveen.
Okay. Very briefly on the statistics, it's not so much about the statistics, this conversation, but very briefly, what we saw was a reduction in the perinatal mortality to about 17 from what was stated for India as about 26, and reduction of neonatal mortality to below 10. It's running from a practice perspective, the possibility of identifying a pregnant woman who is at risk for preeclampsia is possible in the first trimester. And Dr. Sunil, from an obstetric anesthetics perspective or an obstetric medicine perspective, is saying that if we identify them early, we can look at them and we can initiate care at an earlier stage. Dr. Rijo, from the radiology perspective, is saying that we have the mechanism to provide Doppler measures and provide a risk estimate. And this can happen even in the third trimester, where you are able to provide a risk estimate. So it need not be that the assessment of a pregnant woman must happen. Anesthetic assessment of a pre-anesthetic checkup of a pregnant woman must happen only before childbirth, just before childbirth. And that's a big paradigm shift. That's a very big paradigm shift. And that paradigm shift can be understood when Dr. Sunil explains about the decision making, the immediate decision making that must be made on fetal hypoxia, life of the mother, blood loss, all those things that happen in very short time, which can be prevented if we have a sustained, systematic approach to the whole process. So, Dr. Sunil, I would like you to explain also a little to bring the gravity of the situation into perspective, that when it's seen in an acute phase, how difficult is it?
Yeah, see, suppose if the patient comes in acute phase, we have to, it is our prime importance as a part of as a clinician that we have to optimize the mother, because uncontrolled blood pressure per se have a 5-fold increase in incidence of cerebrovascular accident or stroke. Like systolic blood pressure more than 180, persistent is directly proportional to the incidence of intracranial bleed. And if you look at the commonest cause of maternal mortality in the patient with hypertension disorder is intracranial event, cerebrovascular accident. And many a times it is so massive bleed that by the time the patient reaches a specialist center, it's almost inoperable or patient is brain dead. That is the thing. And second thing, which is very important, is 40% of coronary dissections that we see because of uncontrolled hypertension, again, preeclampsia or accelerated hypertension is the underlying cause. Importantly, the retinal detachment, cortical blindness, all these things can happen because of a breach in the blood-brain barrier or retinal artery thrombosis because of accelerated hypertension, which can all be prevented by appropriate antihypertensive treatment. We have an area of antihypertensive treatment. I'll come to it a little later on, but it can be definitely these complications can be prevented. Importantly, again, as Dr. Rijo rightly pointed out, a small chunk of women, especially those who have early onset preeclampsia, from 30, 24, 25 weeks, the incidence of long-term cerebral cardiovascular disease is very high. So, as a postpartum preventive program, also these patients have to be under the surveillance of obstetric physicians. They have every 6 monthly checkups so that we can identify essential hypertension, chronic hypertension, so as to appropriately prevent it. So these are all the things which, as a clinician, as an anesthetist, we need to know. Even not only it helps us in intrapartum, optimizing intrapartum and postpartum care, postoperative care, but also preventing complications on a long-term basis. Again, I would say that when I'm seeing this patient in acute setting, I would like to know which subset of patients belongs to in hypertensive disorders. If you look at the classification of hypertensive disorders in pregnancy, like we have defined preeclampsia without severe features, preeclampsia with severe features. That is, these are the preeclampsia is nothing but onset of onset hypertension after 20 weeks of gestation. And if you go by the definition, a systolic blood pressure of 140 and diastolic of 90 taken 4 hours, 4 to 6 hours apart, you can label this patient as preeclampsia. Or a single reading of systolic of 160, diastolic of 110 can be labeled as preeclampsia. The entity of mild preeclampsia is non-existent today. It has been eliminated from the classification. Earlier, it was like something mild preeclampsia, because that mild preeclampsia gave the clinician some solace that, okay, this is a milder form. But once you have preeclampsia, they can progress to any of the severe features. So when we talk about severe features, what are the severe features as a clinician we need to know? One is fall in platelet count, thrombocytopenia. Other thing is elevated liver enzymes, or persistent epigastric pain, or acute pulmonary edema. If you look at the cause of maternal mortality in 1990s and early 2000, the commonest cause of maternal mortality after intracranial event was acute pulmonary edema, causing respiratory insufficiency, respiratory failure. But fortunately, because anesthesiologists have invaded labor rooms, suites now, you put a tube, optimize, or you put a non-invasive ventilator and optimize the pulmonary edema. We no longer see maternal mortality, pulmonary edema per se. But yes, definitely, if you don't have this know-how about optimizing oxygen delivery in the acute setting of maternal hypoxia, you still end up with a serious morbidity. So these are all the things that controlling the blood pressure is of paramount importance. Seizure prevention. You don't have to wait for mother to throw a fit and then start magnesium sulfate. If you look at MAGPIE trial, which came as early as 2000, MAGPIE has landed. I was the editorial in British Journal of Anaesthesia. I remember still the editorial, where if the patient has imminent signs, or even if the blood pressure is like persistently 160 systolic and diastolic 110, you don't have to wait for patient to have imminent signs. Start magnesium sulfate therapy. It has a huge margin of safety. It's a category B drug. As long as the patient is having adequate diuresis, creatinine is normal, there is no oliguria, you can start magnesium sulfate. It's a safe drug. It is not an antihypertensive agent. It is seizure prophylaxis or seizure prevention medication. And even if the patient has acute kidney injury or anuria, oliguria, you can always give a loading dose safely. Subsequent dose modification depends on other parameters. But control of blood pressure with oral medications or parenteral medications, and optimizing this patient before she comes for surgery or delivery is of paramount importance.
Dr. Sunil, what about fetal hypoxia in this management? I know that the mother is given predominance
Yeah.
as the person to be saved first, and then subsequently the fetus. But how does fetal hypoxia or knowledge of fetal hypoxia play a role in the management?
See, as an OB anesthetist and OB intensivist, we look mother and child as one unit. So whenever we see the patient, our basic motto or premise is giving best to both the lives. So giving best to the mother as well as giving best to the newborn or the fetus. So definitely assessment of fetal condition as a part of preoperative or PNS check is of paramount importance. And the Rijo's finding on the ultrasound or all those things also helps us to optimize and plan perioperative management. Because suppose if I'm looking at a fetal growth restricted mother with FGR, severe FGR, or a small for gestational baby, then definitely from my side, if I'm giving a regional anesthesia, zero incidence of hypotension is what my label, because I don't want to induce any small component of hypertension jeopardizing neonatal outcome. So that is what is important for me. So probably Rijo's finding or his input also is equally important for me to plan my anesthetic.
So the important takeaway that is coming here from what Dr. Sunil is saying is that they need to look at the health of the mother. They need to look at the health of the unborn baby, and there are multiple parameters to look at. And it is always easier if this information is passed to them in a very systematic manner, so they can plan the whole process rather than for everyone it's landing on the table and then in 1 or 2 minutes you are supposed to make a decision. That decision making cannot always be optimal. Many times it will be optimal, but when something does not happen, it's not always a technical fault or a fault of something. It's just that decision making has to happen too fast, and the process is changing too fast, and we don't have the background context in it. Which brings me to a very important aspect of this thing. And Dr. Rijo, from as a fetal radiologist, from a tertiary care center or from a major city, from an advanced care center, you might have requests coming in specifically asking for fetal Doppler or other tests like this. What happens with referrals from other centers or tier 2 cities or non-metro centers or non-tertiary care centers? How does the reporting of fetal Dopplers and fetal ultrasound measures get integrated with the management? Or is there a huge gap there? Is there a lot of work to be done there? What is your perspective on
that? I think this focus on fetal growth and fetal environment in the pregnancy scans came quite late. I think it started coming in 2012, 2014 only. Before that, the pregnancy scans are, even now, it is heavily tilted towards the screening for the structural anomalies and any markers for aneuploidies. The focus, ideally, a comprehensive assessment should be for three things. For one is as we do for structural anomalies, but two more things has to be integrated into the pregnancy scans. That is the assessment of the fetal growth, the possibility, predictive assessment for any fetal growth restriction, and also assessment on the fetal environment. When I say fetal environment, it includes the mother as well as the maternal, the uteroplacental circulation too. So the assessment, because in preeclampsia, conditions like preeclampsia, the maternal factors and the uteroplacental circulation, these two are playing a very significant role. So we can monitor the the uteroplacental circulation much before many of these symptoms starts manifesting. So that is where the role of our pregnancy scans with the addition of Dopplers integrated into that comes in. Of course, the obstetricians has got this gestosis score. The problem is there are a lot of theories there, but on the ground, you don't see most of these things happening. I'll tell you, as Dr. Sunil Pandya rightly said, in Kerala, we see Paili sir has taken a lot of lead and a lot of things are happening here, I can see. But when I went to, as part of this project in different parts of Madhya Pradesh, Uttar Pradesh, we saw in Jabalpur, there are at least 7 to 8 cases of preeclampsia and 1 or 2 cases of eclampsia every week in a medical college. So the kind of incidence that you cannot, it's so high in many parts of India that a screening strategy and the skill enhancement program with the help for the obstetricians and the radiologists and the even all the stakeholders involved in that, anesthetists can help do a early check, early analysis of all these results and avoiding or preventing all these complications. So once it goes into these complications, I think we are putting people like Dr. Sunil in real trouble. And of course, and maybe you will be saving the patient, but the long-term complications rate and all will be considerably high. But we have to devise a strategy pan-India to prevent this thing right from the gestosis core, right from the use of combined screening methodologies. Because as part of our project, a place called Guna in Madhya Pradesh, there is a commendable work that was done by a radiologist. So he himself called as a social radiologist. His name is Dr. Lalit Kishore Sharma. He integrated this screening protocols with the 38 Anganwadis and the district administration. The district collector in Guna, Mr. Frank Nobel, also considerably helped him to launch this project, and that project is called as Barosa there. So what they did there is screen according to the Samrakshan protocols of Indian Radiological and Imaging Association, and now that they systematize it. But before that, when we started it, any day that Guna is a small place, and the nearest biggest town is biggest city is either Bhopal or Gwalior. So to reach either of these places, it is 150 kilometers. So once we see any of these signs, whether it's a stage 1 or stage 2 FGR, and the chances of mother having especially the early preeclampsia, possibility of 24 to 28, there is a possibility of having a early preeclampsia. So there is a considerable delay in the map. Either the family decides to go to this because they've got other issues, financial issues to be sorted out. So we found that there are 3 delays. One, delay in deciding by the family to follow follow the advices of they say that we need a tertiary care management because this may not be possible in a place like here. So that itself causes a lot of delay. Then they've got financial issues. Transportation is another delay. Third thing, once they reach that place, to convince the tertiary care people into taking a decision, because we lost several babies, stillbirths, and once reached once Dr. Sharma was monitoring this throughout and giving me the information what to do next. So stillbirths happen after reaching the tertiary center because they didn't realize the importance of it. And then, of course, in any Indian medical colleges and with kind of workload we have, the getting the proper attention, all these things are a real big issues there. But so what I'm trying to say is, if we want to address this problem, we need to develop all these strategies at the district hospital levels itself, secondary level, right? Rather than depending only on the medical college or the metros or the this thing, because getting there itself is we are losing a lot of precious time in saving the mothers and the babies. Especially so, if you look at the Western guidelines coming out from FMF, and so stage 2 FGR monitor every 3 days, stage 3 monitor 12 days. All these things are not at all possible for 70 to 80% of India. So if it is stage 1, if there is any change, this thing, shift them to a tertiary care center, and if there is any, unless and until these kind of facilities are developed at the district hospital level or the district levels. So India, this is a major challenge. What we are seeing in the tertiary care centers is not the real picture. If we really want to tackle this problem, one strategy as we conceived in some direction, let us risk stratify them at a very early stage of pregnancy and try to modify that risk, reduce that risk by giving low dose aspirin, so that considerable amount of mothers can be saved right from the period itself, who are likely to go for preeclampsia at later stages of pregnancy, and if that is not stratified and modified. The second strategy is again early FGRs, and because FGRs is two types of phenotypes are there. After 32 weeks, that is the late onset FGR, and early onset FGR before the 32 weeks. And in India, we have got considerable overlap between the small for gestation, constitutionally small babies with who are likely to go in for fetal growth restriction too because of the maternal malnutrition. So it's a considerable overplay, complicated system that is happening for our this thing, for which most of the Western guidelines which we are applying in the tertiary care centers may not apply in the rural and the centers below the tier 2 cities. We need to devise our own strategies for that, and the subduction is one such strategy we developed, and I think it is showing considerably good results.
So, would it be justified to say that we have to rethink the paradigm of childbirth? The whole paradigm of pregnancy and childbirth is focused on childbirth. It doesn't look at the mother from the time of conception, and it doesn't feed into the skill sets that are available. A lack of skill sets, a lack of facilities, a lack of infrastructure at a secondary level, primary level, yes. Skill sets that can percolate down are available in terms of what is possible in obstetric anesthesia, in terms of what is possible in obstetric critical care, perioperative care, in terms of what is possible in fetal Dopplers, fetal radiology, fetal medicine, interventional radiology. So a whole set of skill sets are developed. At some point, this is an area which I am happy to state and then get crucified about. But at some point, I feel that the whole focus has been somehow on delivering a child safely, as opposed to the whole processes that can help that happen more optimally. And that's where we get stuck, because someone like Dr. Sunil Pandya, even though he may not state it so openly, or maybe will, often ends up having to firefight without background information. Documentation may be poor. You have a patient coming in with a very severe condition. You need to do all the assessments immediately. And you don't have time. You need to do it in 2 minutes, 3 minutes. Less that time. You have to make immediate clinical decision. You send for lab tests, whatever you send, it will take time to come back. You don't have that time. And you're firefighting. And you have to make the most. You have to protect 2 lives. You have to give 2 lives back, or else a lot of flack comes.
Absolutely.
How do we align the whole process? And that's something that I would like to hear from both of you. How do we align the whole process so that a safe childbirth is an end product of a process?
You brought in a very good point to discuss, Dr. Praveen. I would say that like how Dr. Rijo and his team have standardized assessment from the radiological viewpoint. We made an attempt, and again, Dr. Praveen was one of the mentor. We devised our own scoring system, Saving Mother Score, where we try to identify based on the scoring system, clinical scoring system, based on laboratory parameters and comorbidities. We can risk stratify this woman, and subsequently, even if the patient is at the primary level or a secondary care center or a tertiary care center, we can risk stratify and appropriately stabilize and transfer the patient to a next level depending on the scoring system. So basically, definitely, there are several scoring systems like mini pairs and pairs, and Saving Mother Score is what our in contribution to the Obstetric Anesthesia Society is. This helps us to align and identify a mother so as to optimize and have a prepare her for safe delivery. So that is one thing. And second thing, of course, is medical optimization. Very, very important. I don't have to go into the details, but medical optimization is of paramount importance, because if you transfer a patient who is unstable, who is hypoxic, or who is having irritability, and giving anesthesia to this patient is going to be a nightmare. So we need to see that we sufficiently identify, stabilize, and then plan anesthetic. Either if we don't have know-how, if we don't have infrastructure, then stabilize and transfer. So the protocols, when not to touch the patient, when can you stabilize, how can you stabilize, and how to transfer the patient, all have to be imparted as a part of the basic skill sets among all the caretakers. Because many a times, if the mother lands up with morbidities or complications, it's a multidisciplinary team that gets involved, and we need to have the anticipate the problems also. So aligning, stabilizing is a paramount importance. So you can align and align also only when you anticipate. You can anticipate only when you have the knowledge set. So we have to grind the clinicians on a regular basis, what all can lead to, and this is apt. I think I quoted earlier. But why mothers die issue from Kerala Society of Obstetricians and Gynecology is a fantastic review. That's the only authentic data available in the country, where they have identified, and hypertensive disorders again have been the second leading cause of maternal mortality, and they have transected and dissected every maternal mortality because of hypertension. And if you study those things, most of the problems at a primary level, primary delay, secondary delay, and tertiary delay, third delay, have been elucidated, and we can optimize and we can minimize and have a great outcome for both for the mother as well as for the fetus, neonates.
Now, if I ask a sort of controversial question, how much of this actually, how much of our protocols, how much of our guidelines, how much of our processes actually percolate into the teaching at the postgraduate level? Because are we ending up having to train a minimal number of people who are starting to work or are working as consultants, as opposed to training from a foundational basis?
Yes, that's again a tough question to answer, but I must say that by and large, common conditions, especially hypertension, hemorrhage, more or less, I would say 60 to 70% have been protocolized. And if you look at Embrace audit, mothers and baby risk reducing audit to confidential inquiries, they could reduce preeclampsia death to almost 7th or 8th causes, which was one of the second leading cause, just because of protocolized approach. So why not we? If we just control hypertension, hemorrhage, and sepsis, what Kerala has done, what MMR of 30, we can achieve it. Why not? If you look at national mortality, I mean, still at 211 cases, which is very high. So if you have to come down to 130, it's going to take ages. Even though Telangana report says 52 or 56, but if you look at, I think that's not a correct data, because you look at the data from our own maternity hospital, we see at least 3 maternal deaths happening every month. So that 46 per 1 lakh live birth, I don't think is the true data which the government is portraying. Probably they may be missing many things. So definitely reviewing maternal deaths, grinding protocols, whatever it is, you just have to keep revising and keep grinding. And majority of the time, what the mother needs is, if they have missed what all Dr. Rijo said, clinical optimization. If they can control blood pressure, if they can prevent seizure, if they can identify HELP syndrome. Again, I must tell you that 65 to 70% of HELP syndromes are biochemical derangement. They don't have clinical manifestations. So unless you do laboratory tests like assessment of renal parameters, liver parameters, or platelets, you may miss out till the patient develops bleeding gums or hematuria, which is a very late sign, and only 30% exhibit those telltale signs. 70% is a biochemical derangement. If you can identify, or when to do laboratory parameters, identify HELP syndrome, because once you have HELP syndrome, once you have eclampsia, there is no waiting. Optimize and deliver, because we know the cause. So these are the things that we need to grind to all our colleagues, anesthesia colleagues, obstetricians colleagues, and everybody who is involved in the maternal care.
So, Dr. Rijo, your thoughts on how do we, the two things that I see, one is that three things. One, the ability to take a skill set and transfer it at different levels of healthcare for an optimal outcome. Two, do we have or do we accept enough information that comes from our country as a society, or as individuals, or as groups? Do we accept information that comes from our country, or are we more keen to accept information that comes from other societies for whatever reason? So Dr. Sunil Pandya says, I know I'm wading into entirely politically incorrect areas, but still, like Dr. Sunil Pandya said, the Kerala model, we saw that it works. We don't see that percolating across many other states, many other things. Similarly, data that comes from our own areas, we don't see that. Now, the gap then comes between what is possible to apply and the results that have been developed from.
So, Praveen, I got your question. So, I was just trying to explain one of the reasons, one of the problems that, of course, the health policy makers has to see into a coherent activity from the professionals too, which is not happening right now. The obstetricians see it in a different way. Neonatologists see it in a different way. Radiologists see it in a different way. Obstetric anesthetists see it in a different way. Different stakeholders in pregnancy and childbirth has to come together and to give emphasis to the statistics, perinatal and maternal mortality statistics, and give focus towards a preventive strategy in addressing this particular issue, rather than depending on the guidelines that come from the West, where the fetal growth restriction is less, the maternal mortality is less, or preeclampsia is less. So we need to have a common, all the professionals need to, because why I'm saying this is, even the Obstetric Gynecology Society documents on fetal growth restriction, after highlighting all these things, still they are not advocating a screening combined screening protocol for with the help of Dopplers. So there is a reluctance still at the national society levels. From the radiologist perspective, again, focus more on the congenital structural anomalies, not giving enough focus on the fetal growth and fetal environment. So the comprehensive assessment, just like Sunil had this Save the Mother score, I also had proposed this FIRAD scoring system for a uniformity in the reporting and data systems. That in radiology, there is a to have the uniformity in the reporting and data system. We got the RAD system. So fetal-maternal imaging, reporting and data systems, radiology assessment and diagnostic score is a comprehensive scoring system that I have proposed, considering all three parameters, not only the structural anomaly, but also the fetal growth and the fetal environment, wherein the risk stratification and the parameters that can predict the possibility of a preeclampsia or fetal growth restriction and the various staging of fetal growth restriction will increase the score of FIRADS into FIRADS 5, where a termination of pregnancy is indicated. FIRADS 4 is a guarded prognosis. FIRADS 3 is a reasonable good outcome. FIRADS 2 is a monitoring is required, can be part of a normal variation or a physiological process. FIRADS 1 is a normal finding. Everything is going normally. In these three subsections of structural anomalies, fetal growth, and fetal environment. So what I'm trying to say here is, India should have, the professionals in India should have a strategy for India. We have to talk in the terms that works in India at different levels of healthcare. Whatever that is coming from outside is only for the tertiary case, and there too there is not much of a uniformity I can see, because in a large medical college with large volumes of cases, many of these standard guidelines may not be applied. And a corporate hospital, it can work in a different way, but looking into the volumes we have in India, 70 to 80%, as Sunil rightly said, it happens in the places below the tier 2 cities and the rural areas, the nursing homes, where we need to have a common and preventive strategy, this thing, and a strategy to detect early complications and to at least refer them to a district level where these things can be managed, or to a referral center at a much earlier, because delays are causing a lot of maternal deaths and fetal deaths. And one more thing I want to focus is, as part of the subjection, the second stage that we are planning is, we are now dividing it into focus on stillbirths, focus on preterm births, focus on prematurity, focus on perinatal hypoxia, because that is another issue that has got a long neurological outcomes. So all these things have got common factors: fetal growth restriction, preeclampsia. So if this is a lot of interconnected things that we are discussing right now, if we can address this preeclampsia at a very early stage, the focus has to be given with the gestosis score or the preventive screening with and a proper documentation going to the anesthetist at a very early stage. Many of these complications, many of these things that we are discussing right now can be erased from India statistics. So for which professionals has to put their foot first here and have a dialogue, and that is what I think right now we are having. Praveen has initiated this. Thanks, Praveen.
Yeah. Yeah, one more thing, just answering Praveen questions from anesthesiologist perspective again, whether Indian guidelines or our Indian society's information is being honored. I must tell you that yes, about a decade ago, we didn't believe in our data, and what all West said, we used to gavel it out, and then we realized that what they write, what they say doesn't apply to our setups because we don't have those ideal conditions. And last one decade, what all we have published ourselves, our data from multiple centers, they are being considered, they are being cited, they are being discussed, they are being deliberated. So definitely, what we say, and what we do is being definitely regarded and read by the our colleagues, our fraternity people, and it is having a say. And in fact, that becomes more appropriate for our setups. Like if I'm reviewing maternal why mothers die, embrace audit and why mothers die audit, we know this is audit performed in Indian conditions. Okay, it's a verbal autopsy, but still the sincerity with which the teams are doing the workup and they dissect the maternal cause, we know because the people who are there at the helm of affairs, they know the Indian condition, Indian subset, and Indian rural setups and urban setups and the tertiary care setups, and that's how they have derived the data and they have come to the cause. They may not be 100% accurate, but at least 80 to 90% data is good enough for us to make our own foray and forte. Again,
So
Dr.
best outcomes are possible if we apply
Our own data,
our own data.
Yeah,
Right.
absolutely.
Good.
And
Well said.
they are being delegated now.
Yeah.
Again, quickly, before Dr. Praveen comes back, again, preeclampsia or hypertensive patients are subset not only because of their clinical conditions like health. What I was telling Dr. Rijo was the data from India is very much honored now, and people are reviewing, people are seeing because more or less it is applicable to our conditions, and reporting also is more or less quite accurate. And I would say with the CTRIs and the RCTs registration, more of the studies and results are also to an extent, I would say, data which is being captured truly on a dynamic basis rather than hypothetical data which we have seen occurring in the Western journals also. So data from our journals, from our societies are being relegated, being honored, and definitely we need to look into our conditions and apply to our own subset of patients.
So uh, the important takeaway is that we need to we need to consider pregnancy and childbirth as a long-term continuum and not just as isolated events, especially looking only around the time of childbirth.
Yeah.
We need to have systematic protocols in place. We need to have more dialogues in place because multiple protocols and guidelines are being developed by different societies, professional societies that are involved in the whole process of pregnancy and childcare. We need to improve the dialogues, we need to improve the training systems, we need to plan for a childbirth in a more systematic manner, and we need more evidence coming in from our own settings. We need to evaluate that, the evidence that is generated from our own settings, and we need to translate that into application. Uh, this is a vast area, it's more like an ocean, and we have sort of just dipped our toes in the ocean now. But we have had several interesting insights that have come in. We have gotten the importance of prevention, we have gotten the importance of early identification, we have gotten the importance of providing enough information so that the anesthetist and the radiologist can play a very important role in optimizing the whole process of childbirth, and that can happen throughout all trimesters. So I'd like to thank Dr. Sunil Pandya for sharing his experience with us, and we will have him back with us, and we will be probing more into more details of anesthesia around childbirth and pregnancy and critical care. Thanks to Dr. Rijo Mathew, who has explained about the importance of radiology and imaging systems in optimizing childbirth and how it can help address conditions like preeclampsia, fetal growth restriction. So, a very good discussion. Once again, thanks to all of you, and hope to have you back here soon. And again, apologies for a little of technical difficulties that cropped up, and I sort of disappeared in between. It's a good thing. If you can hear me talk, that's definitely a good thing to you'll understand why I should disappear more often.
Thank you, Praveen, for this
It was
initiative. This is
it was lovely meeting Rijo. I didn't know that so much of work has been done by your association. Hats off to you and your studies, and best wishes for the publications.
thank you, Sir, Dr. Sunil and Praveen, for having me here. And I think we have to continue this conversation with more disciplines,
In
more
fact,
experts from the
I
disciplines.
didn't go into the details of clinical management of pregnancy because
Yes.
I will just have a just overview.
Yes.
Thank you very
So,
much.
Thank you.
thank you. And till we meet again, stay safe, be happy, keep smiling, and keep your blood pressures under check.
Thank you.
Thank you. Thank you, Dr. Praveen. Thank you.